Hello, everyone. Thank you for joining our ACEsConnection webinar, The Trauma Toll on Pediatric Immigrants, Refugees, and Their Families. Our speakers will provide tips for healthcare providers in pediatric settings and beyond. Please show slide 1. I'm Laurie Udesky, a staff reporter with ACEsConnection and the manager of the site's ACEs and Pediatrics community. ACEsConnection supports communities to heal trauma and develop resilience. It's an active social network of more than 27,000 people nationally and internationally. We recognize the impact of adverse childhood experiences on behavior and health and promote resilience, building practices and policies. And we welcome you to join ACEsConnection. Let me go over some housekeeping. I will introduce each of the 3 speakers before they talk. The speakers will answer your questions during the last 15 minutes of the webinar. To write and submit your questions, please click on the icon at the bottom of your screen that says Q&A. This webinar is an hour long, and a recording of it will be available to participants afterward. We have 3 speakers, Drs. Raul Gutierrez, Heyman Oo, and Nick Nelson. Here are some of the areas they'll cover: how to create a space that's safe for these pediatric patients and their families, how pediatricians work collaboratively across sectors in preventing and mitigating toxic stress and trauma, and in thinking about intergenerational trauma. You'll also hear what happens in a forensic exam for refugees and asylum seekers. Dr. Gutierrez, please turn on your video. Dr. Raul Gutierrez is a community pediatrician. He is a clinical instructor at University of California at San Francisco, and he co-founded and directs a multidisciplinary team at the Bridges Clinic based at Zuckerberg San Francisco General Hospital, which serves recently immigrated children and their families. He also works for La Clínica de la Raza's school-based health centers in Oakland, for which he developed guidelines for intentional and thoughtful health care for immigrant students. He is a native of the South Texas border town of Brownsville and developed an early interest in immigrant health. He also serves as an executive committee member on the Council of Community Pediatrics with the American Academy of Pediatrics, and he's on the steering committee for the Immigrant Health Special Interest Group. Dr. Gutierrez.
First slide, please. I just want to say thank you very much for having me today. I appreciate the community and work of ACEsConnection, and I'm happy to be contributing to the mission. As mentioned, I work in the Bay Area of California and split my time between San Francisco and Oakland. Next slide, please. So as mentioned before, I work at Children's Health Center at Zuckerberg San Francisco Zuckerberg General. And as you can see, the vast majority of our patients are children of color, with 55% being Latino. And more than 40% of our families need the use ask for an interpreter as well. The Children's Health Center mostly serves our marginalized communities in San Francisco, and the vast majority of them are on public insurance as well. Next slide, please. Over at La Clínica, we have a much larger institution serving the East Bay of the Bay Area. In 3 particular counties. And if you can see there on the percent of total patients by age, the vast majority of our patients are children and young adults, with 45% being less than the age of 18. And similarly, we also serve a large percentage of Latino or Hispanic patients, with only 5% being on private insurance. So as we talk about the policies that are being proposed for our, with the current administration, we can see that it has the potential of affecting a large population of the patients that we serve at these two institutions. Next slide, please. So fear, an unpleasant emotion caused by the belief that someone or something is dangerous, likely to cause pain or a threat. This is the emotion and its health consequences that are presenting to us in the clinical setting. It is almost inescapable with news of the repercussions of immigration policy on the radio, television, social media, from friends and families surrounding us daily. Some of us may even be affected directly. I'm from Brownsville, Texas, a city on the Texas-Mexican border, now known for the location of a shelter that housed separated immigrant children. There was also a recent story about American citizens along the border being denied passports. Their citizenship was being called into question because their birth was via the assistance of a midwife, and some were accused of falsifying birth certificates. So fear, that's what I felt as I wondered if any of my relatives were born with the help of a midwife, and whether their passports and citizenship would be called into question. Next slide, please. These are some of the current policies in place or proposed by the current administration. And while these policies are veiled in the notion that they are making the country safer, there's no basis for that claim. And instead, we are harming an already marginalized community with health repercussions, not only to those directly affected, but that affect documented and American citizen families as well. From a socio-ecological model, it's important to consider the many ways such harmful policies may affect people and communities within these different spheres and how it relates to health and well-being. Next slide. So let's take the fear of deportation and family separation as an example, which can be felt at the individual and community levels. Children in particular experience direct impacts, including anxiety and symptoms of post-traumatic stress. There is also studies that link such stress to an increase in the risk of low birth weight pregnancies. A recent study found a 24% increase in risk of low birth weight infants born to Latina mothers after a major immigration raid when compared to birth weights before the raid. Losing one working family member places a large strain on the family unit as a whole, as it threatens the sense of safety and economic stability as well. Next slide. We can also view this from a public health perspective and look at how whole communities can be affected. Immigrants change health-seeking behaviors for themselves and their family members if they fear being stopped by police and potential deportation. As described in multiple studies and surveys, immigrants miss medical appointments or are less often use public services like health clinics. They eat less healthy food if afraid to drive. Access to grocery stores with produce and healthy food options often require travel, which may be a deterrent and adversely impact health. And people are afraid to use parks, exercise outdoors, and participate in their communities. Next slide. And children are particularly vulnerable. Nearly 30% of undocumented parents in reports that their US citizen children are afraid either all or most of the time. Nearly half said that their child has been anxious, and 3/4 said that a child has shown symptoms of post-traumatic stress. Children experience direct impacts, including poor child health, poor behavioral outcomes, and poor educational outcomes. Next slide. And in a recent multi-site survey study following enrollment in the Supplemental Nutrition Assistance Program, or SNAP, researchers found that in the first half of 2018, there was a distinct drop in SNAP participation. Only 34.8% of families in the US for less than 5 years surveyed participated in SNAP, representing a nearly 10% drop. This potentially represents the agonizing choice families must make between food security and a pathway to citizenship. Next slide. So looking at this from a different lens, we can also consider how immigration status acts as a social determinant. Policy may affect the way in which social determinants may impact health depending on your immigration status, and that policy's repercussion on your environment, access, and daily living. Looking at all these domains and the potential harms of policy, it's clear that there is potential for long-term stress on a family. Next slide. So taking all this into account, I found my colleagues in psychology to be quite helpful in their approach to working with immigrant families. I find these principles to be helpful in my clinical approach to immigrant children and their families. In particular, liberation psychology framework addresses the underlying power dynamics in human relations and social systems with the aim of transforming inequality and oppression to meet the basic needs of all people. Additionally, consistently engaging and educating oneself is very helpful, as well as engaging and educating others. Also recognizing that there are flaws in research and that there are ways to improve that. Incorporating some type of cultural responsiveness or cultural humility has been really helpful in our approach to immigrant children and their families. And of course, promoting that positive change in your own sphere with regards to the socio-ecological model. Next slide. So toxic stress, experience of strong, frequent, and/or prolonged adversity without adequate support. We know that prolonged stress response disrupts the development of brain architecture and other organ systems and increases the risk of stress-related disease and cognitive impairment well into the adult years. From the socio-ecological model, we need to be aware that such stress for children can be coming from multiple spheres and that their parents may be equally or more directly impacted, potentially disrupting the parental support we fall back on to mitigate this stress. Next slide. And while classic ACEs questions have been documented across ethnic and racial groups, children in immigrant families have unique experiences that are missed or do not fit within the classic questions. So can we extend the notion of incarceration to include the experience of being detained by ICE? Can family separation because of deportation or forced displacement be considered some form of household dysfunction? And how do racism or xenophobia, whether experienced personally or from the community, fit into this model? Next slide. We also must understand the context of the migration experience. Society and politicians tend to focus on the pull, and while these reasons are valid, the push most times better captures the narrative of children and families' need to leave their homes. Next slide. And as we try to understand the reasons for displacement, the push to immigrate, we must be mindful of the journey and the circumstances once in the United States. Immigrant communities may have mental health needs that stem from a host of exposures and isolation along the migration narrative, but more commonly in combination. And while they have escaped their pre-migration and post-migration experiences, the stress and fear they are facing in this country is very real as well. Next slide. And I will acknowledge that the families I work with are resilient, many with very positive outlooks on life. But alongside, there are these common diagnoses and the different components of potential stress and trauma that culminate, resulting in generational trauma in some of my families. Next slide. There have been numerous and growing numbers of studies linking complex trauma and toxic stress to disruptions in the developing brain and other systems. While there are psychological diagnoses, many times this harm manifests itself in clinics and schools with complaints of sleeping problems, aggression, or detachment, and poor school performance, among other symptoms. Next slide. It's common to only think about non-citizens when thinking about immigrant children, or only focus on one subgroup, such as refugees. However, children who are citizens can often live in mixed citizenship families and are similarly affected by such policies. The vast majority of children in immigrant families are US citizens. In some areas, more than 85%, approaching 90% of children are US citizens in mixed citizenship families. Next slide. And I put this here, we're not gonna play this video, that wasn't supposed to be there. But I put this slide more to talk about the interactive models in terms of acculturation stress. Next slide, please. And particularly, those aren't supposed to be there either, I apologize. In particularly thinking about patterns in second generation acculturation and thinking about the difference in how a parent is acculturating versus a child, and how there are cultural differences that are sometimes in conflict and can also contribute to a stress within that family dynamic. Next slide. And so in our clinics, we take an ecology of needs approach and try to incorporate all these different spheres into promoting resilience. So looking at medical legal partnerships, really defining our medical protocols for our approach to care, making sure that we have mental health integrated into our systems, making sure that access is not a problem by working with our eligibility workers to get insurance in a timely manner, participating in advocacy in any way that we can, and making sure that there's a good support system, not only within the family, but also the community that these children and families are in. Next slide. And so we also look at some principles of social justice in terms of how we approach our care, really looking at our families' rights, their self-determination, with a particularly focus on access and equity, and their participation in their own care as well. Next slide. And so we have what we call some tailored primary care, introducing the concept of a medical home. And when we bring all these resources, what that means and why they are coming to doctor's appointments and in what ways that we can help them. Establishing some guidelines, as I mentioned before, but also building strong connections with our communities, particularly with our school districts, and making sure that our policies and procedures aren't getting in the way of the care that we want to provide. Next slide. Our history and assessment is trauma-informed. We try to screen and look into ways in which our families could have been traumatized, either the parents or the children, or a combination of the two. Next slide. We also take cultural considerations. Some of my mental health workers use the addressing model when working in multicultural contexts and with immigrant refugee communities. As you can see here, there are different components that we incorporate into our assessments, including things like development, disabilities, religion and spirit orientation, cultural identities, and so forth. Next slide. We also have a HEADS adaptation, in including all the HEADS questions that we ask our adolescent patients. We also look at things like the age of migration and how that impacts one's experience, one's language proficiency, the amount of discrimination or social exclusion that they're experiencing. What are your educational barriers, and are your schools meeting the needs that you need? Are you working? And is that employment environment dirty, dangerous? Is it degrading? And also looking at generational status and that relationship as well. Next slide. And although there's a lot of bad, we also want to look at the positive. So what are some things that we can ask that are protective factors? So positive family dynamics, positive peer relationships, a strong sense of identity and belonging, or participating in extracurricular activities that are meaningful, but also identifying that development can be affected by things like racism, discrimination, lack of value placed on migration or life experiences. And some of my slide got cut off there. But next slide. And I also understand that there are many communities that may not have a lot of resources that we might find in a metropolitan area. I do look sometimes to these national and state organizations for support and help, and also to form community for families that don't necessarily have it in their environments. And using this approach, I think, has been really helpful. I think there have been lots of examples in my practice where just asking that extra question, for example, a teenager and what their plans are after graduation, we ask about college, but then don't consider that some of our patients might be eligible for DACA or might have to renew their DACA. And that can be a significant barrier to them if they don't have it. Also thinking about how our children born in the United States are affected by families who've been deported. There are multiple times where I've asked, and at first families say everything's okay, but really when you dig and you ask thoughtful questions, sometimes it comes up that a family might have been deported, a family member might have been deported, and that has a significant impact on the family that maybe they didn't want to share with practitioners. But that's our approach in our two different clinics. I hope that was helpful for you, and I'm going to pass it on to our next presenter.
Thank you so much, Dr. Gutierrez. I want to remind everybody to click on the Q&A icon at the bottom of your screen to submit questions. Our speakers will answer questions after the presentations, so we will talk to them about that there. Our next speaker is Dr. Heyman Oo. She is a primary care pediatrician at Marin Community Clinics, an associate physician clinical instructor for the General Pediatrics Department at Zuckerberg San Francisco General and UCSF Benioff Children's Hospital. She completed her residency in the Pediatric Leadership Advancing Health Equity Residency Program at UCSF. And in the last decade, she has worked with various migrant and refugee populations in multiple capacities here and abroad. She has provided direct clinical care for immigrant patients, coordinating multidisciplinary partnerships with health departments, community-based organizations, and schools to develop programs to serve newcomer populations, as well as advocating for immigrant policy change locally and nationally. She is currently the pediatric champion at Marin Community Clinics for a pilot project with the Center for Youth Wellness that screens for adverse childhood experiences. She is the co-chair for the AAP Chapter 1 Advocacy Committee and is a board member for the San Francisco Marin Medical Society. Dr. Heyman Oo.
Thank you, Laurie, for that kind introduction. And thank you, Dr. Gutierrez, for that excellent background information on the challenges that the population that we serve faces day to day. Could I have my slides up, please? Okay. So just a little bit of background on where I work and our community. So I work at Marin Community Clinics, which is a network, it's a federally qualified health center, and we have several clinic sites throughout Marin County. It was founded in 1972 by a number of volunteer physicians in a church basement by the local county hospital in Marin County. And since then, it's grown to be the largest safety net provider in Marin County. So we actually have comprehensive primary care health services. We're a patient-centered medical home. And so we have oral health, we have behavioral health, we have OB services, as well as vision services, an on-site pharmacy, radiology. We're very lucky to be able to provide these services in-house for our patients because we recognize that it's difficult for them to go outside sometimes to obtain the services and care that they need. Can I get the next slide? And then, so where we're located, I don't know if you guys can see on the map, but we serve over 34,000 patients annually, and about 40% of those patients are pediatrics, so similar demographics to Dr. Gutierrez's clinics in the East Bay. We're located just north of San Francisco, across the Golden Gate Bridge, and our population is similar to La Clinica's population in Oakland, in that 96% of our patients are below the federal poverty guidelines. The vast majority are either on public insurance or uninsured. And most of our patients, over half of them, 66%, identify as Hispanic or Latino and primarily non-English speaking. Can I get the next slide? So I'm going to be talking about, how do we translate all of the information that Dr. Gutierrez was giving into the actual data encounters that we as providers have with our clinic and our patients. Given that there is all this fear in the community, I know that a number of my colleagues and myself feel like what can we do to help mitigate some of the fears that our families might be facing. And so I'm going to go into kind of walking through what a clinical encounter could look like in terms of being trauma-informed and being sensitive to the needs of our immigrant families. So nothing in this presentation is legal advice. I know that this is national, so that a number of you will have to refer to kind of your local laws and what's appropriate where you are located, but there are a number of good websites nationally that have guidelines that you can refer to. Specifically, I want to draw attention to the California Primary Care Association. That website is there on the slide. There's a toolkit on the Everyone Belongs Here website that has policies and procedures for various clinical sites, and then also the National Immigration Law Center that you can register and access their toolkit on how to prepare your clinical site to be more sensitive to immigrant populations. Can I get the next slide, please? So in terms of creating safe clinical spaces, you know, a lot of these things seem like common sense, but then really taking the time to evaluate whether or not your clinical space and your clinical encounters can be improved in some way. So focusing on having a welcome environment with clear signage that is explicit about the values of your organization with regards to immigration. And then also having explicit policies and procedures where you can educate your staff as well as your patients about their rights and what to do in various situations that might be uncomfortable or concerning that could, you know, potentially traumatize families. I'm also going to walk through kind of what a clinical encounter can look like to be more trauma-informed. Can I get the next slide, please? So the first thing is, you know, having the first thing that your patients and families see when they walk in. A number of the families that we serve, you know, they are newcomers, and so their experiences with the medical system is very limited, and so oftentimes they're very overwhelmed by what they have to do. Often if they try to get their child into school and they were told to come to our clinic first. And so, you know, just having your front office staff be very comfortable explaining the policies and procedures and having signs in multiple languages that state that they're welcome here and that this is a safe space and that there are resources that they may not necessarily associate with health clinic to begin with, but then they would come to realize that these are resources that can be attained in your location. Can I get the next slide, please? So in terms of clinical encounters, the way that we do all of our newcomer visits is that all of our newcomers' families get a packet of information. On the first page is, again, stating that they're welcome here and that we're happy that they're here, that it doesn't matter, you know, where they were before, but we're here as a team to help them be successful in whatever comes from this visit. And so one of the first things that we do is we talk about insurance. Is there some way to make the slides larger on the presentation view so that people can see? So on the right side, I don't know if it's visible to the participants, but we have a handout of how family members can obtain insurance in our county. And I explicitly explain that, you know, most of the children are qualified for insurance through our various public insurance programs, but oftentimes the parents themselves are not insured. And so I make an explicit comment that, you know, they should talk with one of our enrollment counselors, that they may qualify for certain services or have some portion of their care covered, and that it's not possible to have a healthy child without having healthy parents, and really stressing that it's the health of the family that we're focusing on. Can I get the next slide? So this is an example of our ACEs screener. And so as Dr. Gutierrez mentioned, a number of the classic ACEs categories have a different flavor when it comes to immigration and immigrant family. And so if you can read the questions, we basically consolidated a number of the ACEs questions into categories, including family separation or separation from a parent, either due to divorce, incarceration, or immigration explicitly. And so what we ask families to do when we hand out the screener as part of their packet is to read the different questions and anonymously, in a de-identified way, just write down the number of possible situations that their child has been exposed to. And we use that, and we explain also explicitly the reason we collect this information is because that stressors can affect a child's health. And so we just want to know how much stress this child, their child may have experienced in their life thus far. And we've actually never had a family decline the screener. There is, some explanation that needs to be done sometimes about, how to actually fill out the screener. From a cultural standpoint, it's a lot of paperwork that they're filling out when they're coming here for their first visit. But most of the time, families are quite forthcoming with what their children have experienced. And we found that all you need to do is ask in a very sensitive and compassionate way and make it clear that the purpose is not to, you know, just be nosy, but for more that these sorts of things can affect the health, and that we have resources and that we have ways to help mitigate the possible downstream effects on their child's health. Next slide, please. So we have a local organization in Marin County called Canal Alliance. I would encourage everyone to reach out to your various community-based organizations. The Canal Alliance is our go-to organization for all things related to immigration, and so they also have a nice packet of information that we include in our intake packet with, you know, outlining people's rights, helping them make a family emergency plan, information on how to obtain legal resources. And again, we include that in our intake packet for newcomer families, in that they're starting to hopefully realize that the clinic is their medical home, and that we have a lot of connections with a lot of resources outside of the clinic walls, so that if they're having trouble that may not traditionally be related to their health, that they can always come to the clinic and we can help them navigate the situation. Next slide, please. So the page on the left is basically an outline of our behavioral health services. And so again, with every, one slide back up. There we go. So basically with every intake, we talk about some of the stresses related to immigration, that it's a complicated process, that you can have mixed emotions, that children can be happy to be here and it's, you know, exciting, but that in a couple of weeks, maybe they'll be sad because they're missing their friends or their other family members that they've left behind. And in speaking in these general terms, you normalize that the immigrant transition experience can be difficult, and that this assistance that we're offering in terms of behavioral health is always going to be there. So even though it's not something that they necessarily view as a need right now, that in the future, if they want, if they notice any behavioral problems, and some of the behavioral health problems that Dr. Gutierrez outlined, like problems in school or problems with sleep or, you know, chronic abdominal pains, that the seed is planted for these families that there may be something else going on in addition, and so that they can reach out to us. The sheet on the right of the slide is just a guide of, again, community resources in Marin that include all sorts of things, you know, phone numbers for the YMCA, employment benefits, assistance with housing, again, to create the atmosphere that the clinic is their medical home. And what that means is that we are here to help in all aspects of their life in whatever way we can. We don't make any promises, obviously, because resources are limited, but we want the families to understand that if they're having difficulty, that all of these different ways can affect their child's health, and so that we want to be a part of trying to find the solution. Next slide. Next slide, please. So the last two pages, one is information about our dental clinic, so that kids can also focus on their oral health in addition to their medical health and behavioral health. And then the sheet on the right is our weekly health fair that we host, that also has a food bank, a community food bank that comes and kind of holds like a farmer's market for free. And so anybody in the community can come and just grab a bag full of food once a week from our food bank. And so we definitely identify that, because we do know that, you know, newcomers coming into a place can have difficulties with food insecurity and that sort of thing. And so we want to make sure that they're aware of the resources that we have. So moving on to the kind of larger policy and clinical policies. Next slide, please. To think about. So in terms of creating these clinic spaces, I know that there's been a lot in the news over the last 2 years about ICE raids and what clinics and other sensitive locations can do. So there are some protections under a memo from 2011 that ICE is discouraged from conducting immigration enforcement activities at the following locations: so schools, hospitals, churches, funerals. And so there is some reasonable expectation that in a place where a person could expect privacy, that you do have rights to protect that person's privacy. And so, again, having explicit conversations with your clinical leadership of what that means for your institution. Next slide, please. I hope everyone's familiar with the red cards. So on the left, that's just an example of red cards. If you Google red cards, you can order them, but they basically are portable little cards that you can hand out to patients, have them in the waiting room, have them in the clinical room, that people can take and use as a way to communicate if someone shows up at their door and that they don't actually have to open the door, they don't actually have to speak with whoever is there. And so I always give it out saying it may not be appropriate for you, but if you know of anybody in your apartment complex or if you think that this might be useful, to be able to give that. And then also having signs, again, explicit in multiple languages in your clinical waiting areas or in your exam rooms that say that, you know, if ICE comes to your door, here's what you can do. And then the last slide that I have, next slide, please. So the last slide is, can be found on the websites that that were on the first slide. But basically, it's an example ICE protocol. And so again, with your clinical leadership, training your staff, your front office staff, whoever might be the ones encountering any potential visitors to your campus, on what the procedures will be if someone shows up, and that not everyone, you know, has to be allowed onto campus if they don't have an official warrant. So I think these slides are going to be made available through the ACEsConnection presentation, and so you can review the details there. But I'll give up. So yeah, that's what the protocol looks like, and the workflows. And actually, just like you do earthquake drills here in California, or you do, unfortunately, active shooter drills, you know, having an unanticipated visitor drill with your front office and your back office staff might be something worthwhile given your population or who you serve. Okay, thank you.
Thank you so much, Dr. Oo. That was just great. And I just want to tell people, I know that there may be some technical issues with the slides being as large as we would like them to be. We will be sending those out to folks. So don't worry about that. And I also want to remind you all that if you do have questions, there is a Q&A icon at the bottom of your screen. Click on that, submit your questions. And after our next speaker, then we will be able to start the open Q&A. So I would like to, hold on one second here. Dr. Nick Nelson graduated from St. George's Hospital Medical School in London in 2008 and completed an internship residency and chief residency in internal medicine at Highland Hospital in Oakland, California. Dr. Nelson serves as Associate Program Director for the Primary Care Internal Medicine Residency at Highland and as Medical Director of Highland's Human Rights Clinic, and as a member of the Advisory Board for Partnerships in Trauma Recovery. His clinical and academic interests include primary care internal medicine for underserved populations, bedside diagnosis, healthcare for newly arrived immigrants, forensic medical and psychological evaluation of asylum seekers, and the medical and psychological care of torture survivors. Dr. Nelson.
Hey, I'd just like to say thanks for inviting me and letting me be part of this. It's been really great to hear my co-presenters. Can I see the slides? Thanks. So I have kind of a slightly different background. I'm not a pediatrician, I'm an adult medicine doctor. And I do general adult primary care for lots of people who have a lot of ACEs and other forms of trauma. But what we really do in the Human Rights Clinic is forensic evaluations for asylum seekers. So that's kind of what I'm going to talk about in these slides. So we're going to change gears a little bit. Can I have the next slide? So just some basic terms and definitions. People often use refugee and asylum seeker kind of interchangeably, but legally a refugee is someone who is granted status to come to the United States in their country of origin. And there's a process for undertaking health screening that's associated with that. An asylum seeker is someone who comes to the United States and then seeks political asylum here. And that can be by legal or by legal means or without documentation. And typically there's no health screening involved in that. An asylee obviously is someone who's been granted asylum. And then there's a couple of special visa types for specific populations that I'm not going to go into in any detail. Next slide. So can you click the next slide? Thanks. The demographics of our patients are kind of similarly diverse to the statistics you've been seeing from my co-presenters. We have some interesting preponderances that are based on communities that we have here in the East Bay. So there's a really vibrant East African community that's mainly composed of Eritreans with some Ethiopians. And then there's a large Central American community with a lot of people from the highlands of Guatemala who are indigenous and speak Mam, which is a Mayan language. So interestingly, there's more than half of our patients are either from Guatemala or from Eritrea. And then the rest of them come from all over the place. Alameda County being either the first or the second most diverse county in the country, depending on which statistics you look at. Next slide. One back, yeah, there you go. So this is actually an old slide. We're closer, I think we've evaluated more like 400 patients now. About half of them are female. The majority come from Eritrea and Guatemala. About 59% of them have been tortured, and about 32% of them have had female genital mutilation, which reflects the prevalence of that practice specifically in Eritrea. The next slide. Back, yeah. So there's some recurring themes that we see over and over again that are kind of based on local country conditions. So Eritrea, for example, which has been in the news a lot recently because of the cessation of hostilities with Ethiopia, has a highly militarized state where everybody's subjected to compulsory military service, which is often open-ended, and it's very easy to fall afoul of the authorities and get imprisoned. The prisons are extremely inhumane. There's a lot of forced positioning torture and a lot of beating. In Guatemala, there's a lot of anti-indigenous racism, and the people we see have often been victims of that. We see a lot of people also from the Northern Triangle, from Central America, who have been subjected to recruiting efforts by gangs, and if they resist those, they usually end up becoming victims of violence or having violence perpetrated against members of their family in an effort to compel them. Next slide. We see, not just from Mexico, but from throughout Central America, we see a lot of persecution of LGBTQ people, a lot of intimate partner violence, and a lot of cartel-based violence. And then we have a number of patients from West Africa where there's also a lot of persecution of LGBTQ people and politically based violence and assassinations. And then FGM, we kind of treat separately because the evaluation process is a little bit different. And that occurs in a big swath of countries across sub-Saharan Africa and the Middle East. But most of the patients who we see who've been through that are from the Horn of Africa. Next slide. So the way that our clinic works is we get referrals from immigration attorneys or from local immigrant advocacy groups. And sometimes patients find us through Google or get referred from the emergency department. We determine if they need a forensic evaluation or not for their asylum case. If they don't, then we provide primary medical care and psychotherapy. And if they do, then we do the forensic evaluation and then do a sort of psychiatric and social needs assessment and try to get them plugged in with all the appropriate resources. Next slide. So I'm going to talk briefly about the kinds of things that we see in the clinic. The things that we mainly end up seeing and documenting are dermatologic, musculoskeletal, neurologic, and psychologic consequences of torture. So I'll talk a little bit about a couple of those. Can you go to the next slide, please? We see a lot of non-specific findings like residua of abrasions and lacerations and stuff like that, which can be helpful to someone's case. But the things that I'm going to show you are more specific signs of torture. So these are, if you look at the picture on the right, these are what are called tramline bruises, and they're an appearance that results from beating with a blunt linear object because the skin at the margins of the impact zone gets stretched, and so there's subcutaneous bleeding there, but not where you actually get hit with the thing where the skin is compressed. Next slide, please. These are ligature injuries, which are caused by being bound tightly for prolonged periods of time. We see these in our Eritrean patients because they often, a form of punishment in the military, there is forced positioning. And there's a couple of different positions, but the most popular one is what in English is called hog tying, and there is called auto, after the Italian Italian number 8, because the way it's done is the ankles are bound together, the wrists are bound together, and then the ankles and the wrists are bound to each other behind the person's back. And the longer you stay in that position, the more likely you are to get injuries like this. These can also be associated with nerve damage and sensory and motor problems distal to the injury. Next slide. And these are, so on the right here, this is a young woman who had a pot of boiling water poured onto her legs, and you can see that the scar actually like follows the rivulets of the water as it runs down. So this is a highly specific and helpful kind of physical finding. And then this is a young boy who was burned by gang members with lit cigarettes to try to compel his mother to cooperate with them. So I'm going to end on the next slide. So I probably don't need to spend too much time with the audience that I imagine has been attracted to this webinar talking about the specifics of these things, but obviously a lot of people have physical sequelae from torture, but virtually everybody has psychological sequelae from torture. PTSD being probably the most common thing, and then every permutation you can imagine of anxiety and depression. And another thing that we see a lot is that I think that the core experience of PTSD is probably universal to a large extent, but the way that people express psychological distress is certainly also conditioned by their culture and by their culture's model of mental illness and of psychological stress. So we see a lot of people who present with somatic complaints primarily that turn out to be driven largely by psychological distress. And I'll just, this is an example that I use of this a lot is this patient who we saw who came to the hospital for weight loss and rectal pain, and he had lost about 100 pounds in 6 months, and everybody's immediate assumption was that he had some kind of metastatic cancer. So he got every investigation that you can imagine, was discharged essentially without a diagnosis, came back to the hospital 2 months later with the same presentation, got a number of other tests that he hadn't had the first time, also discharged again without a diagnosis, came to primary care clinic like 3 or 4 times, where people actually asked him whether he had a history of traumatic experiences. And then finally, someone asked him specifically if he had been tortured, and that was when it turned out that he had actually been imprisoned in Yemen for 3 months and tortured very extensively by the government there, and all of his symptoms related specifically to the psychological sequelae of those experiences. So yeah, just to wrap up, I mean, I think what our clinic does is a little bit different than what's been described in terms of building a trauma-informed and community-responsive primary care clinical environment. We're more about a very specific forensic service that is instrumental in helping people pursue asylum claims who are pursuing asylum claims. And that's a minority of the undocumented immigrant community, and even a minority of the people who are probably eligible to pursue asylum claims. Because a lot of people, I think this is changing, but a lot of people who are definitely eligible either don't realize that they're eligible or can't afford the legal assistance that they need to make a claim like that. So yeah, thank you.
Thank you so much, Dr. Nelson, and I want to thank everyone else. Also, let's get everyone here. We're going to start with the questions. And I also want to remind everyone that the recording of the video will be available for participants. And before we begin answering questions, I want to also encourage everyone to join ACEsConnection and ACEs in Pediatrics, where there's a whole forum where you can discuss these issues and more. I guess I want to start by asking Dr. Nelson, when you, what would you suggest to people who are healthcare providers in other parts of the country and would like to refer a patient to somebody like you? How would they go about that?
we usually get referrals for the forensic stuff. We usually get referrals from lawyers. If you're looking for like so if you're looking for that and you're not near a clinic that you know does that, the best thing to do is contact a national organization called Physicians for Human Rights that runs a nationwide network of volunteers who do these kinds of evaluations. So that's the best thing to do.
Thank you. And I also want to ask each of you actually to talk about, these are tough issues, talking about trauma, talking about, opening up the conversation with your patients. I wonder if you can each give an example of how you open up a conversation to make people feel more comfortable.
I can start with that. I think, so first, I think it's really important to recognize in your clinical setting, what is the population you're working with and what is the potential that you're working with immigrant families, to really understand the need and see how common it is in your clinic that these things might actually be happening, these type of stress, these type of traumatic experience might actually be happening to the patients that you serve. I do it, I think, in different ways, and I think it can come up in all different aspects. Most of the time, this comes up for me in my social history. It may be at a physical exam. It might be at a new patient appointment, but it usually comes in my social history and along everything else that we talk about and normalize, whether that's talking about gun safety, car seat safety, the risk of falls for a kid or anything like that. I try to normalize that a lot of families that come to this clinic are immigrant families, and these are the ways in which sometimes that can affect your health. I would like to ask you some questions that might be personal and sensitive to you. At any point, you can tell me that I'd rather not answer that question, and or that you'd rather not have me document that into your medical record. And I think just normalizing that and understanding that there are a community of people that are around you that may be experiencing these things is helpful, and to acknowledge that. For me, that tends to really open up the conversation. Certainly having some linguistic matching and sometimes cultural matching can be very helpful for opening that conversation. I will say that our clinic does not serve a high population of Chinese immigrants. I recognize that we don't have the language experience with it. Some of us don't have all of the cultural experiences around that. And there are other clinics who do wonderful work in San Francisco who might do a better job of that. And so that is also part of my counseling, and to say, do you feel comfortable here? Would you rather have someone who speaks your language or who understands your experience? And that's okay with me.
Okay, Dr. Nelson, I know that you're going to have to leave soon, so why don't you jump on and if you could respond to that as well.
Yeah, I would echo everything Raul said. And I'd also say, for my line of work, it's also very important to be completely transparent with people about why I'm asking the questions that I'm asking. Because often it's very difficult for people to go to, people with severe PTSD who've had really traumatic experiences spend a lot of energy trying not to think about them. And then to come to a doctor's office and have someone be like, hey, I need you to tell me every single detail of this thing that you're spending most of your time trying to forget is not easy. So for me, it's really important to sort of lay the groundwork and explain exactly why I'm doing this, to help them understand how this is supposed to be helpful to the lawyer who's trying to help them get their asylum case completed, and exactly what the expectations of confidentiality that they can have are, just so that it's very clear why we're doing what we're doing.
Great. And Dr. Oo, I know you covered some of that, but I'm just wondering, you had talked to me when we spoke before about how you use the ACEs screener. That's one way of opening up conversation that might lead to that. I wonder if you could expand on that.
So similar to Dr. Nelson, Dr. Gutierrez, totally normalize the experience, be transparent about why you're asking the questions that you're asking, because it's true, again, most of these patients may not know the purpose. Why is this related to my child's vaccinations, or why is this related to my child's, belly pain? And so really having that conversation and doing that psychoeducation, that as a child is growing up, these sorts of things can affect the way that they feel, and all of the health is related, is important education for them to receive just baseline. But I think it sets the tone that, we are here as a caring institution to help promote a healthy family. And again, giving them the sense of control. So with our ACEs screener, when our MA is handed out, we explicitly say, you don't have to fill this out, but the doctor would like to know these things because we know that some of these experiences can affect your child's health. And so if there is anything that we can do to help you, your doctor would like to know, and would, we'll talk to you more about the situations. And again, I think that, with ACEs screening and the different pilot sites that are doing different forms of ACEs screening, there's always the question of a de-identified questionnaire versus an identified questionnaire. We find that 50-50% of our patients end up writing yes or no next to the questions anyway, but it does, again, give that sense of control that if someone doesn't explicitly want to talk about something, they don't have to. And we don't necessarily in that visit dig deep into which of the ACEs, but we do say, oh, it looks like your child has had a lot of stress. Do you think that this could be manifesting in any certain way? Do you have any concerns? And eliciting the parents' concerns and kind of tying that together if it clinically makes sense. Again, we're lucky to have in-house behavioral health, and so we can pull a behavioral health provider if someone, seems to be wanting assistance right that moment, or we can just broach it and be like, oh, sometimes when children have these experiences and then have these behaviors, parents find it helpful to have them see one of our behavioral health providers so that they can work through strategies on how to not feel this way anymore. And so again, normalizing it, and it's true, there is some cultural stigma to behavioral health, but I think every question and every step of the process is to make the patient feel comfortable that whenever they're ready, that they can disclose things, and that we'll be here to help them in whatever way we can.
Thank you. I also was wondering, I know both you, Dr. Oo, and Dr. Gutierrez work with Fuerta, which is this kind of coalition, a cross-sector coalition. Can you talk a little bit about how that coalition works, like what would be an incident or an event, how you work together in order to give an idea for other pediatricians in other parts of the country about what happens on the ground in this kind of situation?
So specifically for Fuerte, this is a program that's in San Francisco that was born out of a cross-institutional collaboration with the San Francisco Department of Public Health, the San Francisco Unified School District, and the providers, the pediatric providers at San Francisco General Hospital. And so I think, as Raul mentioned, Dr. Gutierrez mentioned in his presentation, your school districts, generally speaking, are, if you can get in with your school district, they are very, very good friends of yours. Since these kids end up spending a lot of time in schools, more time than they'll ever really spend in your clinic. And so the 4-year program is at its core a behavioral health intervention, but it links community behavioral health providers, brings them into the schools, trains them in a specific curriculum that's more or less a newcomer curriculum that talks about the immigration process, strategies on emotional resilience, emotional identification, builds that community in that school. And then if there's any triage that happens and someone needs higher level of care, they can be connected to outside resources outside of the school. So it's nice in that it really brings all the players to the table and helps bridge the different institutions and kind of break down those silos that may traditionally be there.
Raul, Dr. Gutierrez, I don't know if you had anything else that you wanted to add to that?
No, I think the Fuerte groups are really fantastic, and there's been a lot of positive response from the participants and the behavioral health specialists who have run them. Over in the East Bay, what's been happening at the school-based health centers mostly, they've been taking components of things like CBITS program. So that's the cognitive behavioral intervention for trauma. That's right. and taking components of things like fuerte and kind of combining them. That's also been very helpful for a lot of students. I think the important thing here to realize is that sometimes these structured types of interventions don't always fit from a language, cultural perspective, and that a lot of the people running the interventions find that they tend to have to alter them a little bit. And it's really fantastic. The youth are really into being like, well, can we do it this way? Can we try it this way? Maybe we can do this activity instead, but still really captures what the intervention is trying to do. But being open to youth informing these interventions, I think has been really key to making them successful and not being so rigid.
One of the questions from a participant is, are there cultural barriers to accessing behavioral health? And I think in some ways you just answered part of that by talking about how you let students kind of play a role and how they do things. I wonder if you could answer that question and perhaps go a little deeper into some of the things that were shifted to make it more culturally
Yeah, I think I caught most of that question. So yes, there are lots of challenges. One, there's just not enough behavioral health specialists to do one-on-one interventions. And I think what we found, and what I think a lot of the approaches now is to look at it more of a tiered approach. So one, at the base, having a trauma-informed practice and being able to recognize how to screen for such trauma or recognize that toxic stress or trauma is happening. Two, seeing what level of intervention would be appropriate for the youth. Not everyone needs one-on-one interventions. Is it short-term? Is it long-term? Can it be done in groups? And that's been really helpful to kind of mitigate the shortage of the amount of providers that are out there. And it also helps with the language barrier, which I think is a big one. And that language barrier might be different depending on where in the country you live and what your immigrant community looks like. But one of the examples that I think where the kids were changed the curriculum a little bit, or the approach, was they didn't want to go home and do homework and write out their thoughts and things like that. Instead, they were more interested in having, what we call pláticas. So really sitting around and talking to each other about their experiences and learning from each other. And that was just much more helpful for them to get their thoughts out and to share those experiences. Some of the activities, they changed to be more culturally appropriate for them. In one of our particular girls groups, they really wanted to do more sewing and making of jewelry and things like that. And that was really helpful. And in some instances, we were able to connect some of those students with mentors in the community who are already doing that work, either as their own business or as a collective. And that was really helpful for some of those students as well.
Well, thank you. Thank you so much. There are a number of other questions that unfortunately we won't be able to get to because it looks like we're running out of time. But I do want to let people know that we are going to be, this is recorded, we will be sending out a link. I want to thank so much to our presenters, our panelists, Dr. Raul Gutierrez, Dr. Heyman Oo, and Dr. Nick Nelson. We will also have a blog post on ACEsConnection about this webinar, which will include a link to the recording as another way of getting a hold of it. And we may answer some of the additional questions that were posed and not answered. So at this time, I want to thank you all for joining us, and please enjoy the rest of your day. Bye-bye.